A lot of health centers do not have in-house pharmacies. So if someone comes and gets a script written from a community health center provider, there's no pharmacy on site.
You're providing discounted medication to people who lack access or who need it most and lack resources.
You can purchase drugs, which are often very costly, at a discounted rate.
What are the biggest threats to the program right now? Okay, so what if there was a federal program that was the key to healthcare for millions of Americans, affordable healthcare for millions of Americans, especially those who need it most? That's what we're going to talk about today. So welcome to Community Health Centers Unfiltered. We are a podcast where we talk about policy and politics and the people who are driving healthcare specifically for community health centers, but honestly across the space and where they intersect with health centers. My name is Amanda Pears Kelly. I'm the CEO of Advocates for Community Health. And today we're going to talk about why 340B matters more than ever to America's healthcare safety net. And I am so excited because we're with one of our team members, but also an absolute expert when it comes to 340B. She has been a member of the ACH team since literally day one, and maybe even before that when it was just an idea. Joining me is Elizabeth Lee. She's the managing director at Continuum Health Group. She is a leading expert on 340B, was at HRSA when a lot of these policies were being put in place. And so there is literally no one better to have this conversation in terms of what this program is, because it's big and complex and it has grown considerably, but the importance of it to community health centers, what's at stake right now, what may and may not be coming down the pike, and what we can all do to help inform the direction of the program. So with that, I'm really excited. Elizabeth, how are you?
Great. How are you? I'm so happy to be here.
Do you want to just introduce yourself quickly? Just sort of like your background, because obviously you are the managing director at Continuum and you have this background with 340B and HRSA, but you've done a lot. You've been an expert for a long time.
Yes. So you're basically just saying that I'm old, which is fine. I am old. But I've been working in DC for almost 20 years on health policy. So I started on the Hill, but I spent most of my time in government at HRSA. So I was a political appointee under President Obama, and I spent a lot of my time on 340B and just trying to make it more transparent and accountable, and sort of ran up against some of the challenges and issues we'll talk about today that unfortunately persist a decade later.
They sure do.
Yes.
So just to get us started, because I feel like 340B is it's like some people know it to scratch the surface. Yeah. Some people like you know it to get really into the weeds. Yeah. But a lot of people don't know what 340B is. Yeah. So can you just kind of give an overview of the program, and then specifically, like, why is this program so important to health centers?
Well, first of all, I don't think they knew it was going to be so important because we never named it. Like 340B is literally the section of the statute that authorized like this program, which is so crazy. It'd be like if we called the health center program 330. Like it's just no one ever imagined that it would be so big. Yeah. So it dates back to 1992, and it was designed to be a drug discount program for safety net entities, really with community health centers in mind. So if you are eligible for the 340B program, which all community health centers are, you can purchase drugs, which are often very costly, at a discounted rate, and then generate revenue for your health center. And so for health centers, they have to reinvest that revenue into patient care, anything that improves the delivery of health services. And it was really Congress back in 1992 recognizing that community health centers have such a large mission and so little federal resources to deliver on it. So 340B was really meant to augment that.
So can we hone in on that a little bit? Because I think when you hear the connection to reduce cost of medicine, or just I'm trying layman's terms here, or someone who's not in the healthcare space, the impression is that that's a discount that the public is accessing, but it's bigger than that. So can we just hone in on like what it was intended for? Because I think that's the other thing, is that the intention of the program at its inception is maybe different than how people, when you just see sort of like headline or top line information, they're sometimes at contrast with each other, at conflict in each other.
Yeah. It was never meant to be a discount program for individuals. So it's never meant to be like, I, Elizabeth, need this discounted drug, so I can get it under the 340B program. But I can go to a community health center and say, I am at a certain percentage of the federal poverty level, and I need a sliding fee scale. And our health center is required to do that because they had been able to purchase the drug at a discounted price. So it was always meant to be a discount program for the entity. But with community health centers, they're, as you know, required to have a sliding fee scale for all services, including drugs. And so if a patient can't afford a medication, then the health center can give it to them at a free or reduced cost.
So the beauty of the program in a way is that it actually is accomplishing two different mission critical elements.
Yes.
You're providing discounted medication to people who lack access or who need it most and lack resources. And the health center, the entity, is accessing additional resources as a result of the program in order to support that mission. And in the case of health centers, I'll just add, they have to account for every single dollar that goes through the system. Yep. And so there's also like incredible transparency and accountability.
Yes.
Correct?
Yes. 100% correct.
Yeah.
Yes.
So, and if memory strikes, because we're both old.
Share that trait.
So 20 years this year with health centers, which is crazy. But if memory serves, there actually has been a couple of different occasions to verify that in terms of like how health centers are using it and the transparency and accountability. But you want to speak to that? Just sort of some of the history?
Yes. So there's been many, so there's nothing in the statute, I think because in 1992, Congress didn't imagine how large this program would get. But there's nothing in the statute to say you have to spend any dollars generated under 340B on any particular service, whatever. Mostly because they trusted community health centers to know what their patients needed and what their community needed. But over the years, Congress, HRSA, has said, we probably need to know where this money is going. I think last year, I'm not going to get this dollar figure exactly right, but $50 billion in purchases under the 340B program. I mean, these are major dollars in the healthcare system. So we probably need to understand, okay, what is that revenue being used for? And so that's something ACH strongly supports, is increased reporting and accountability. But there's been a lot of disagreement among some of the key stakeholders, so between Congress, HRSA, pharmaceutical companies, hospitals, about how and when that data should be reported. So ACH and Continue, like we are working to try and get to an answer, like a final policy answer on that, because we really do think health centers and other entities could do a better job about reporting what they're doing with the savings. Like we're really proud, health centers are really proud of what we're doing with the savings. It's incredible, but we need to keep working with policymakers to make sure we get to a good answer.
Yeah, and also worth noting, because there is data that comes out around the total picture of the program, and most recently, health centers were like a sliver.
5%.
So when you're talking about $50 billion or whatever the figure is, health centers, part of that pie, 5%.
Yes.
So it's not a small amount of dollars. I will say that it's a vitally important stream of revenue for health centers.
Yes.
But I do think it's interesting that if you look at the big picture and the entire pie, health centers are just a small sliver.
They really are.
Yeah.
And yet outsized in terms of impact of what they're able to do with the dollars, because they take all comers. They serve so many uninsured and underinsured people. I think we're learning a lot more about what they cover for folks who come in with insurance, but maybe not great insurance, a high deductible, or like, and so a lot of times they're using that 340B savings to make sure that person has all the care they need, even if their insurance isn't covering everything.
Yeah, I mean, and I know you hear as often as I do, but I'd love for you to elaborate. But like, I hear about or from health centers very regularly that if 340B did not exist, they would not be able to provide access to specific services and care. Maternal health being a big one, where because it is such a cost loss or revenue loss for health centers. But, you know, honestly, we were just having a conversation earlier today about the realities in rural parts of the country. It's a loss no matter where you are, but the needs in terms of maternal health are massive. Yes. And unfortunately, there aren't the dollars. There's not a stream to support that. So is that a good example of
That's
how...
a perfect example.
Others?
I was just talking to a community health center, I believe in Oregon, where a site for maternal health, they have other services there, but if it was just the reimbursed services, they wouldn't have enough volume at that site to keep it open. So they have folks that come in with insurance and they can generate revenue, but they couldn't, without 340B savings, they could not keep that open on a regular basis. So this is about, it's ensuring rural access and ensuring rural access to comprehensive services.
Yeah.
And more rural hospitals are closing, as I'm sure you talked about with other guests, and health centers are there to step in and fill the gap. And they could not do that without 340B.
No, and then there's a ripple effect. I mean, like this, again, these are kind of recurring themes, but the ripple effect, you know, if you really... the loss of those dollars would mean loss of access to care. So if there are no other maternal health providers and the rural hospital closed down, people are out of luck.
Yeah,
and then you're talking about, you know, sad scenarios where, you know, potentially even loss of life. But
Yeah.
We'll save that for later in the conversation, the bright picture there. But
and can I make one thing on the other side, but
please.
Opposite of treatment? So a lot of our health centers are excellent at prevention and community prevention. Mm-hmm. So mobile services are not always readily reimbursed by all payers. So I also hear from a lot of health centers that use 340B savings to like have the van equipped with everything they need to do mobile mammography and everything. So this is really, I mean, it's connecting to what a lot of policymakers are saying today about like, can we prevent chronic disease before it starts, or can we manage chronic disease before it gets out of control? That's what health centers are doing with 340B savings.
Yeah. I mean, I appreciate health centers so much. Obviously, this is, a joy for me. But in light of all the challenges, I'd love for you to speak to like why in recent years has 340B become that much more important for the safety net in general, but I mean specifically for health centers in this case.
Oh my gosh, so many things. Where to start? Workforce comes to mind immediately just because there's such a horrible shortage of workforce at all levels, physicians down to, front desk admin folks. And 340B can help fill some of those gaps if you don't have the workforce to generate reimbursable services. I mean, the pandemic, I know we don't like to talk about it anymore, but the pandemic was really disruptive for a lot of health centers. There were influxes and outflows of money, and it was very unpredictable. And 340B is one of those revenue streams that is consistently there and is flexible. So it's not like you are getting reimbursed for an individual service. You're actually generating revenue that then you can use to plug the holes. And so, that's what we hear from a lot of the ACH CEOs is that if 340B went away, it would be removing the one completely flexible funding stream that they have to move around if they lose a behavioral health provider and they need to quickly get contract services or whatever it is. That's really like their backstop, their rainy day fund.
Yeah, I think that's the other piece that I think, again, there are sort of recurring pieces that come up in these conversations, one of which is like health centers don't have the flexibility, to your point, to change their rates.
Right.
So right, wrong, indifferent, it doesn't matter. The reality is if you look at, the cost of providing care, the cost of workforce, the cost of goods and services, like as those things have come up, their rates have not necessarily kept pace with that. So it's not like a private practice or a hospital or you name it where, like inflation or just increased cost. Yeah. And they can adjust for that in order to sustain less of a loss. Health centers don't have that opportunity. And then I'm going to also sprinkle in there that like their grant situation hasn't changed,
no,
right?
It has not. We've been dealing with 4 short patches or whatever. I can't even remember how many we're on now, but so in the Affordable Care Act, there was this CHC trust fund. I don't think we ever imagined that we would be setting ourselves up for this torture, but it was supposed to be like a mandatory backstop for some of the discretionary year-to-year appropriations fluctuations. But really since 2018, it's been, will it get reauthorized? Will it not? Do we have 6 months of funding? Do we have 12? And like, what other provider do we put through that kind of agony? I mean, you would not you would never do it. So, and I think it's because health centers are so resourceful and thoughtful that we don't really hear them like complaining about it as much, but it's a horrible position to put them in terms of like, I don't know. Yeah, maybe it'll come down to the wire. We'll just have to see. I mean, that's really hard to put people who are running like community organizations that are so important. It's just a tough position to put them in.
Yeah, 100%. And I think it's, I feel like the chart is going inverse in terms of like, okay, the cost of providing care is going up. Their grant dollars have stayed flat, but also inflation. Yeah. So it's just a really rough scenario. And I think just to be clear, the grant funds haven't changed since 2018. No. Right?
No.
So there are more dollars that have come to health centers, which is amazing.
Yes.
But the grant dollars, which is really meant to be for underinsured, uninsured, and then other services to be able to cover the bases and the true needs of the community, those dollars haven't changed. So,
and since 2018, we've had how many natural disasters that our health centers have responded to? And I mean, had facilities destroyed. And I mean, there's been a huge, one of the health centers, ACH members was telling me they use some of their 340B funds for just like building renovation because they need the AC to work and the ceilings not to fall in. So like this is truly about like facilities and maintaining the basic costs of care, not even the extras. So
yeah, I think that's right. Well, and that was one of the things I wanted to actually talk with you about is sort of like how are the health centers actually using the savings? Like where is it going? And maybe we can talk a little bit about, like we were saying before, like every dollar that comes through the center has to be tracked. But where are the savings going?
So it's really into chronic disease management, chronic disease prevention, and also that rural access piece. So ACH is launching, I'll do a little teaser, for later in the summer, we're actually launching a project doing transparency around ACH member savings with 340B and really aligning it to some of today's health policy priorities. It's really fascinating to see how folks are using it because it's not the same in every center, which is the idea. Like you're supposed to be meeting your local community needs, but it really is those like rural access services. Sometimes it's like tech that otherwise isn't reimbursed in this, or like wearables and other things that aren't reimbursed in the state yet. So it's really exciting to see the whole span, and we're going to do a really interesting project, I think, on how can we demonstrate to policymakers that 340B, without any cost to the taxpayer, I should mention, is helping them deliver on their policy priorities, because this revenue is generated because of the discounts. There's not a cent of federal dollars that is spent for delivering this benefit to health centers, but they can use it to really build towards a much healthier America long term.
Well, that actually, so two pieces. I'm so glad that you brought it up because I think that even some folks on the Hill may not realize like, the benefit of this program in so much as it's, I mean, if you think about health centers are the largest provider of primary care in the country, 32.5 million people. But a lot of what's enabling that right now are those 340B dollars. But to your point, that doesn't come from Congress. Nope. That's not taxpayer dollars. Nope. That's literally a program that is allowing this incredible access from every corner of the country. Yeah. So it's worrying to me when I hear certain conversations about, and we're all for reform, or I would say, like, I think reform is actually needed and can be really important. Yep. If done properly. But I think it's tricky, right? Because it's sort of, I look at it and I say, okay, but we're in a really precarious position. You know, we had some conversations about Medicaid earlier and some of the cuts that have just come through in terms of that. We've, talked a little bit about the reality in terms of health center funding specifically. All of these things are unstable, to say the least. 340B is also unstable too, but it's actually kind of the best deal for Congress, right?
For sure. And I don't know if newer staffers know that. Like if you reduce 340B and you want to make sure that health centers can still deliver the same services, it's going to cost money. It's going to cost money to replace those dollars. So, and it's why I think we're embarking on this transparency project, because I don't know that it's the trust but verify. I think they believe us, but they want to see the data of like, but really tell me how much money you're generating on 340B and then tell me where those dollars are going. And we want to do that. And so if there's no requirement from HRSA, then I think ACH wants to be a leader and show that actually transparency is possible. And we think that Congress will actually really like what we have to say and demonstrate.
I think so too. But I am curious, like from your perspective in all the years that you've been doing this, but kind of more recently, like what are some of the misconceptions about 340B and sort of what you've encountered and what it looks like for health centers, but sort of in general. And even, not to name or call anyone out, but I think sometimes when I see things in the media, it's like, well, but you kind of like cherry picked little things here. So what are the misconceptions that you run into?
I think that health centers abuse the program. That is the biggest myth and misconception. And it's kind of like, to do what? Like, it's not like, I think any of the ACH CEOs would laugh. Like, it's not going to my salary. I mean, I think it's that health centers abusing the program, I think, is only that they are not required to report. Health centers have no place to put the dollars except back into patient care and making their health centers the best it could be. And I think people don't really understand how the contract pharmacy piece, which we haven't mentioned. So a lot of health centers do not have in-house pharmacies. So if someone comes and gets a script written from a community health center provider, there's no pharmacy on site. So they will then go to Walgreens, let's say, and get their health prescription filled. But then the 340B savings have to sort of like go through Walgreens back to the health center. And so I think a lot of folks in Congress are like, well, why is Walgreens making money off this program? It's like, well, Walgreens, they have to be paid for dispensing the product, but Walgreens is not getting rich off the 340B program. They're actually enabling the access that health centers need. So, there's certainly, again, more transparency that could be put around those arrangements. But I think people think this is just making, rich companies richer, and it's not going to the people that need it. So I think I would love to just sit every staffer on the Hill down and explain to them why contract pharmacies are important.
Yeah, they're vitally important, particularly in rural areas.
Yes.
Yes. I think that's the thing about this is that if it were easy to do this, it would have already happened.
Yes.
But it is complex in terms of like how things need to be reworked. But I do also appreciate what you said, which is like health centers are operating, the national average, I think, is like a 1% to 2% margin. So I don't,
They're not getting rich.
To your point, it's like, what are we talking about in terms of abuse of these dollars?
Right.
Exactly. It doesn't exist. I mean, honestly, yes, of course, there are bad apples or there are bad scenarios or there are mistakes. So, but I think this, again, kind of is a nice segue to that's the importance around the transparency and the accountability, which health centers are willingly stepping into and already doing in some cases. But I'd love to hear more about, there has been a lot of debate on the Hill and a lot of discussion around like, what does the added scrutiny look like and what are the biggest threats to the program right now? But where do you see threats, but also maybe opportunities?
I think the biggest threat is that thing that you brought up earlier about the misconception around patient benefit versus entity benefit. And I think ACH and community health centers really need it as an entity benefit. And I think the biggest risk on the Hill is the misunderstanding, like, no, this should be a patient discount program, which it's just never how it was intended to operate. And so I think ACH and others are trying to do as much education as possible about it being an entity benefit. But I think that misunderstanding sometimes leads to well-intentioned reforms that would have a really negative impact on community health centers, especially limiting contract pharmacies and others. I will not go into the boring details, but I think it's a lot about the staffers and members not connecting it to like, oh, what will the impact be in my community if my community health center, even my local rural hospital, loses access to 340B? Like, we need to really tell that story better. And I forgot the other part of your question.
That's okay. There's a lot. And I have more questions for you. Okay. Not surprising. One of the other things I wanted to ask you about.
Opportunities.
Well, opportunities. Let's talk about that first.
Okay. I do think, because I honestly do believe that the reforms are well-intentioned, I think that the transparency and accountability stuff, there's such a huge opportunity. Because if we can tell the stories and other entities that we know are using the program really well, some of the Ryan White clinics, for example, like, we would love to be able to have a standard way, work with HRSA, or AHA or whatever it is, to report on our 340B savings. And we have some really good ideas about how to do that. So I think even if there was an interim step about like, okay, let's do a year of just like seeing what entities use their savings for and then reassess the program, like that would be ideal. So I think the transparency, accountability, we have voluntarily said we will be audited more. Like, please come look at what we're doing with these dollars because we believe in it. I think there's an opportunity, and I hope that that's a bipartisan opportunity, because we saw the Sustain Act last year, which is supposed to be worked on again this year with a group of senators that call themselves the Gang of Six on 340B. And they produced a really, really thoughtful document that had some really good reforms and really, I think, well thought out transparency measures that we were excited about.
Yeah. I mean, I think that's one of the things I hope folks will take away from this. Lots of walks who I'm sure are listening, but I think there is such a willingness on the part of health centers to work together to achieve a reform that keeps the program intact and protections in place so that the program can continue to support health centers and other entities that are using it as intended, again, with the accountability and transparency. But I will also say sometimes there's unintended consequences. And so what does that look like in terms of if there are changes or cuts to 340B? What does that look like for patients? What does that look like for health centers?
Oh, I can't even think about it. I think it's just, it's hard to disentangle this from the reconciliation bill that was just passed. So we're looking at, 2 years from now, seeing like really major Medicaid cuts coming down. And I don't know that some health centers can survive the reduction in Medicaid and a 340B reduction. I really don't. I mean, obviously some will be better off than others, but that's taking the two biggest contributor to their bottom lines. And so I feel like then you can treat patients with Medicare and commercial insurance, which was never meant, that was never the design of what, community health centers were meant to be. So I think it's, health centers have built this patchwork between like the 330 funding, 340B, Medicaid. They sort of have this this house of cards. And so you can maybe pull one and they can figure it out, but two just seems like a death knell to me, which it's scary. It's scary. And I don't think patients who go to health centers have any idea, like they love their provider. They love the health home that they have. I don't think that they don't know what 340B is. They shouldn't need to know what 340B is, but in 2 years when the health center's not there anymore, they're going to wish that they had, been able to advocate or been able to understand how some of these policies impact their care.
Well, I think two things. I think that's the reality, that if it isn't happening now, it's coming. And I think, we get this question on the Hill a lot, and from the media and from everywhere, every corner, where it's like, well, what is the impact? What does it look like? What are health centers doing? And it is cutting back services. Yeah. It is site closures. Yeah. It is continued strain on workforce, which quite frankly, there's already such a strain on workforce. So I feel for health center leaders and honestly health center workforce as a whole, because there's just fires everywhere right now. I know. So this is one where I feel like this can be a win. Yeah. It really can be. Yeah. And I think going back to, I think there's such a willingness on the part of health centers and certainly ACH and others who are working so hard on this issue. But I think here's our next question. So what does it look like in terms of the role of advocates, the role of patients, and sort of how do we help to educate lawmakers in this space, and what needs to happen in terms of what is under consideration for 340B right now?
I don't think staffers and members get to hear from happy health center patients, because why would a happy health center patient ever advocate, right? They're happy with their primary care provider. And I don't have a great answer on how to do that, but I want them to understand that health centers are delivering such an invaluable service to their communities now. And the people who have diabetes and can see a counselor regularly and have access to their medication because of their health center, they're never going to go out. They don't even know to advocate, right? Because they're having a good experience. So I want to be able to tell that story better, of the success stories of we reached this patient who was, in and out of the hospital, and we were able to stabilize them, and now they cost the Medicaid program. To tell those positive stories, because I don't want them to think that health centers are driving this fraud and abuse narrative, because we're really not. And again, as you said, there's always, a bad apple or two, but most health centers have quality of care and patient access top of their mind every single day. Yeah. And to have to say okay, shoot, how many patient visits can we squeeze into one day so we can and then it's no, you're turning health centers into the primary care that people don't that, and so we're squeezing them back into that really hard, it's the reason, and you and I have talked about this before, it's the reason that Walmart couldn't figure out primary care. Right? It's a reason that Dollar General was maybe we'll get delivered primary care. Never mind. No, we can't. It's because it's this delicate patchwork of federal funds, private funds that health centers have figured out. And we're going to force them back into this really hard financial situation that I don't think will be best for patients, which will, kill the leadership. But not a happy answer. Sorry.
That's okay. But there can be, so I'm going to flip it, because I think what you always do. Well, here's the thing. I think what you just spoke to is that's the job of advocates. It's ACH. That is us engaging our members to have that conversation, to do that education on the Hill. And honestly, a lot of what's happening with 340B is also playing out in state capitals. Yeah. So there's, it's kind of on all fronts. But the other piece is, and where I want to flip it, is this is also the responsibility of policymakers to really do the due diligence, to understand it, to get past those myths. And I know that there are, between the Gang of Six, I know Senator Cassidy has done a lot of really great work on this, including engaging with a couple of our members who, basically shared all of the data and came through and said, see, we told you, everything is above board. And I know that office, at least from what we understood coming out of it, was really pleased with what they saw. So I do think it kind of goes back to policymakers and I guess that's another question, sort of like, what happens next? Like,
Yeah.
Obviously, don't we all wish we had a crystal ball?
Yes.
But what do you think is coming as it relates to 340B?
I do think there's going to be a couple new draft bills. So I think kind of the 2.0 versions of what we saw in the last Congress, which we're excited about because we want to engage with policymakers in the House and the Senate. I think there's also bipartisan interest in the House and the Senate. So there's the Energy and Commerce Committee for the wonks out there, the Energy and Commerce Committee in the House, and then the Health Committee in the Senate that have both said they're interested in doing reform efforts. So, and they've both been very transparent and engaging with advocates in terms of like, here's the draft bill, give us feedback. So I think that there's going to be an opportunity to weigh in. I don't know, given sort of the environment on Capitol Hill, I don't know how far that legislation will go, but I think we always hope that, HRSA will be able to follow in some of those ideas, even without legislative action. So if we can agree, like, okay, this is what Congress intent might be, then maybe HRSA could do like a pilot program on transparency and reporting or something like that. Because I think, just following the calendar, like we're going to have the rest of this year, then it's going to be an election year. So I think 340B with a really challenging set of stakeholders who all have a lot of vested interests and opinions, I think it's going to be hard to move something.
Yeah.
But I think our hope is that we can have a really robust, in-depth policy conversation that can still move the field forward.
Yeah. I'm going to call out to, I don't know, maybe we use this, maybe we don't, but I think it is also really interesting when I speak to health center advocates and others sort of in the healthcare space. It's worth noting that it is also really hard in terms of compelling policymakers to take this on.
Yeah.
Because you have behemoth interests in the space who have opposing positions in terms of what should happen with this. And, they're not insignificant donors. And it's a question of like, well, who do you want to take off?
Right.
Or who are you going to take off?
Right.
And then on top of that, because it does not create savings and it's not coming out of the federal budget, there's also no incentive really for them to do anything outside of like, well, we should do something because the program has grown, so wildly beyond where it began. But I think, again, eternal optimist, I think that there's an opportunity for us to...
I agree with you.
Yeah,
I
know you do.
Yes.
I know you do.
Yeah.
The other question, though, I was going to ask you is that there's sort of everything that's happening on the Hill.
Yeah.
But there's a lot that has actually, changed and is happening at the agency level.
Yes.
So can you speak to, what does that look like? Because that's a huge change and shift recently, too.
Yeah. So the Trump administration and Secretary Kennedy proposed in their budget to have 340B move over to CMS, which has sort of been tossed around over the years, just because there's so many ties to CMS programs, Medicaid, Medicare, et cetera. We obviously have a soft spot for HRSA because it's where health centers live. But my take was that it was a potentially really positive move. I'm not an attorney, but there are some regulatory authority issues with 340B, and I don't know if it's easier that it sits inside an agency that has so much regulatory authority. So I am cautiously optimistic about that move, and my understanding, again, not an attorney, is that the reorganization is moving forward, and once there is an Administration for a Healthy America under which HRSA sits, then 340B will sort of fully move over to CMS, but there's still kind of a shared program at the moment. But we've always had, Continuum and ACH has always had a great relationship with HRSA and CMS, and they've been very receptive to our outreach and feedback on 340B over the years. So I think wherever it sits, that seems less important to me than making sure that they are engaging with the advocates and that we have people inside the agency that really care about the program.
Yeah, it's everywhere. It's all over the place. Okay, so one last question for you. So looking ahead,
yes,
what do you see as the future for the 340B program and for community health centers?
I think that if the 340B program could be how many times have I said transparent in this conversation? But if people immediately associated 340B with, expanded access to care, or, primary care for 30 million Americans, and not just, that's that weird program that's has to do with pharma and something. I want them to have a positive connotation to it. I want policymakers and folks on the street, I want them to understand 340B is one of those federal programs that sits next to Medicaid in terms of an access leverage point. But we're not going to get there until we have more information about how the revenue is being spent. So I really think I'm so proud of ACH for leading the way on some of that accountability and transparency work. And I think I would love to see, even 5 years from now, us have better data across all the entity types of like, okay, it's great you have the Access to 340B program, but what do you do with it? And, qualitative and quantitative data, that's a dream to me as someone who deeply cares about the program, but also cares about, access to primary care for vulnerable communities. We want to make sure that it's delivering on its promise. And I absolutely think we can do that.
Yeah. I think I would also just say, I think we have in recent years especially come to a point where, I think health centers worried at a period of time about like, oh no, like this is a really important stream of revenue. We don't want to get something wrong or draw attention or whatever. Yeah. But I think we're now at a point where like, nope.
We're past that.
The more that you can share that really highlights the value and the importance of the program and how it is allowing to fulfill the mission and expand that access. Yeah. So, stand in the light is what I would say with it.
And if you can't stand in the light,
then we need to do some work to get to a point
there.
I think that's a really good point because I think like there is optimization, there is efficiency, there is always opportunity to improve, and I think that health centers are also really willing participants in that respect as well. But I do think it's about standing in the light and really calling out how incredibly important this program is, literally to making sure that people have access to care and specific services for all the reasons that you just mentioned.
Yeah.
I am so grateful that we got to talk about
so fun. My favorite topic.
It's just, I cannot emphasize enough how important the program is, and we're so grateful for your help and your support and your wisdom with all of it. If our conversation today resonated and was important to you, there's a lot that you can do in this conversation. And as always, if you have questions, you can always reach out to us. You can reach us at advocatesforcommunityhealth.org. But also, if you're so inclined, then subscribe and you can catch our podcast, Community Health Centers Unfiltered. We will continue to have this conversation because it is a topic that, one, is a huge priority, but is continuing to unfold, and we want to keep track of it and make sure that you guys have all the information that we can possibly provide and be responsive to your needs and your questions. But another big thank you to Elizabeth, and thank you so much, everybody, for joining us today, and we'll see you next time.